and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Perioperative Care for the Pituitary Patient, Optimizing the Surgical Experience, is presented by Dr. Varun Kshettry. Dr. Kshettry is a neurosurgeon specializing in skull base and pituitary disorders at the Cleveland Clinic. He is also the director of the Advanced Endoscopic and Microscopic Neurosurgery Laboratory. He is an assistant professor of neurosurgery at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Dr. Kshettry received his BA in philosophy at the University of Pennsylvania. He earned his medical degree from Northwestern University. He completed his residency training at the Cleveland Clinic, during which he performed a research fellowship in skull base and microsurgical anatomy at Ohio State University. He then performed a clinical fellowship in minimally invasive cranial base and pituitary surgery at Thomas Jefferson University under Dr. James Evans. Dr. Kshettry has authored more than 100 peer-reviewed publications and book chapters and is an editor for a book entitled Endoscopic and Keyhole Cranial-Based Surgery. He serves as an editor or reviewer for multiple neurosurgical journals. He serves on the Value-Based Healthcare Committee for the North American Skull-Base Society. He serves as faculty director for the Cleveland Clinic Pituitary Tumor Board and is an investigator in several multi-center pituitary clinical trials. Dr. Kshettry collaborates closely with pituitary endocrinologists, neuro-ophthalmologists, otolaryngologists, pituitary pathologists, and radiation oncologists for multidisciplinary care for patients with pituitary diseases. Dr. Kshettry, thank you so much for your involvement with the PNA's webinar program. There will be a brief delay as we change presenters.
All right, thank you so much for the introduction, and I really appreciate the opportunity to talk to the PNA about a topic in pituitary surgery. As I was thinking of a topic, you know, I was looking actually through the library, which is quite extensive, great resource for patients. But a lot of the talks I was looking at are a little more geared towards a scientific basis of some aspect of pituitary disease, surgery, endocrinology. And I thought it might be a nice resource for patients to talk about a little bit about what to expect and a little bit about some of the issues and care paths that we institute for patients who are having pituitary surgery. And so a little bit of this talk is, if I were to rename this talk, would be to say what to expect when you're expecting to have pituitary surgery. I have one disclosure with a company. I don't think that has any relevance to today's topic. And I also wanted to provide the disclaimer that the purpose of this talk is to provide general education for the PNA group, and not necessarily to provide medical advice to any one specific patient. So we'll outline for our talk. We'll talk about some general things to expect if you're going to undergo pituitary surgery. We'll talk about some of the aspects of pituitary or perioperative medication management, including antibiotics, steroids, pain medicines. We'll talk about nasal care and nasal precautions and a specific discussion about management of sleep apnea. And we'll talk about how we assess outcome, both with MRI, assessment of pituitary hormone function and vision. And lastly, we'll talk about some specific aspects towards complication avoidance. So first of all, what to expect. I think if I put my shoes in my patients who are undergoing pituitary surgery, a lot of the fear comes with not knowing what to expect. And I think one of the biggest compliments I can get is where after surgery, a patient tells me, however it was their experience, they say, well, you know what, it's exactly how you told me, it would go, or I knew what to expect. So I think part of the education for patients is really going through different aspects of not only surgery, but recovery, and really talk about how you can expect that they will feel. When we talk about sinus symptoms, when we do surgery in the sinuses, I often describe that to patients after surgery, you'll feel like you have a sinus cold. You'll feel some sinus pain, some sinus pressure that can radiate around the head and the face. Most patients in the first few days do need some pain medications, but most patients, I would say on average by day 3 to 5, can get back down to Tylenol or Advil alone. And most of the sinus symptoms really get better in the first couple of weeks, that kind of congestion, stuffiness. But really for full recovery of the sinuses, I tell patients that it takes a good 2 or 3 months. And what are the things that linger in month 2 or so? One is that there can be increased dryness in the nose, maybe some increased crustiness or boogers compared to normal. And also sense of smell and taste can sometimes temporarily get affected, and it can take up to 3 months for that to fully come back to where it was. In terms of length in the hospital stay, I'd say most patients on average, it's about 1 or 2 nights in the hospital. But I do tell all patients that we can see hormone fluctuations, and in particular with diabetes insipidus. And in about 10% of patients, we may have to keep them a few extra days while we wait for those fluctuations to kind of go away. In terms of time off work, that's a very dependent thing based on what kind of work a patient might do. Is it more physical labor with heavy lifting, or is it more desk work or a managerial position? I think most patients on average tend to take around 4 to 6 weeks off of work. People who have heavy lifting jobs often may need closer to 6 to 8 weeks. It really depends on the flexibility of the job. If someone's in a job where they can go back and do a couple hours and then say, okay, to their coworkers, I'm done, I'm tired, I want to leave for the day, and that's flexible, yeah, they could maybe even go back earlier than that 4 to 6 weeks. But if your job is expecting you once you're back that you're full-time 8 hours, no other accommodations, then it makes sense to take that full-time off. The bottom line is everyone has different financial, social, job circumstances. But what I caution patients is you don't want to get caught in this situation where you've agreed to go back too soon and you're not ready for a full 8 hours of work. And the one thing that can lag behind is energy level. So really to do a full 8 hours work at your work and not get fatigue, I think can take that time. Driving, I think, is a little bit specific to 2 things. One is, of course, to your own provider. You should discuss that with them. But also what's going on with your vision. If you're just talking about from a surgical perspective, in most cases, you can be okay to drive after about 2 weeks. but we have to make sure that you're not taking any narcotic pain medications, that your vision is okay, and also that you and your family feel comfortable with you driving as well. Let's talk about some of the perioperative medication around the time of surgery. So let's talk about antibiotics. So there really is no clear standard of care for antibiotics for pituitary surgery. Now, the majority of neurosurgeons pretty much all give a intraoperative IV antibiotic, meaning when you undergo anesthesia, you get a dose of antibiotics. And I'd say the majority give an IV antibiotic for about 24 hours after surgery. And the evidence of that really comes from some prior studies in craniotomies. Craniotomy means opening the bone or the skull for removal of various pathologies, and some large meta-analyses showed that 24 hours of IV antibiotics decreased risk of meningitis, and that is extrapolated to our population of pituitary patients. In some cases, some institutions may do a swab of the nose to see if you're a carrier of MRSA and adjust antibiotics for that. That's shown some benefit in large groups of all comers, meaning any kind of surgery, not specific to pituitary surgery, so it really hasn't been studied in this population. Also, the duration of antibiotics. Some providers may give antibiotics for a week in a pill form after surgery, and there's really no standard. This was a study I was involved with where we surveyed surgeons in the North American Skull Base Society, and we found a very wide variation in practices with antibiotics. Antibiotics in some cases were less than 24 hours in the IV, but in some cases were 48 to 72 hours after surgery. We did see some variations depending on whether you had kind of a straightforward transcellular pituitary surgery versus an expanded endoscopic skull base where there's more wide opening in the spinal fluid spaces. We did see a wide difference in use of post-operative oral antibiotics, and that could be for a week, 10 days, or even more. And also that varied depending on whether the surgeon used splints on the septum or various degrees of packing in the nose. We also saw a wide variance in which antibiotics to use, ranging from kind of simple, straightforward first-generation cephalosporin to a little more potent third and fourth generation cephalosporins, and in some cases, dual agents. This is a clinical trial that is in the process of wrapping up that we participated with a Barrow Neurological Institute in Jefferson. And hopefully this will give us some answer to this exact question. This is a randomized placebo-controlled trial looking at the use of oral antibiotics after pituitary surgery. So in this trial, all patients got 24 hours of an IV antibiotic. That was kind of, we considered standard. But the thing that we checked was, okay, after that, do we give oral antibiotics for a week versus a placebo? And we're investigating to see if that has any impact on how patients rate that their sinuses are healing after surgery. So hopefully in the next year or so, we should get a final report and answer for this. How about perioperative steroids? The first thing we have to do is make a preoperative assessment to see how a person's adrenal axis is functioning. So most patients may start with a AM cortisol. Cortisol is the body's natural steroid. If we measure steroid function throughout the day, it's up and down like, a zigzag graph. And really the most reliable time to check it is in the morning. So we like to check it sometime between 7 and 9 a.m. This is taken from endopractice guidelines published in 2016, where they said, okay, if the morning cortisol is less than 3, we consider that that patient has a deficiency and we start replacement. If it's greater than 15, that's considered sufficient. And if it's between 3 and 15, we may proceed to something called an ACTH stimulation test. So what is that? That's a 1-hour test where patient will have a baseline cortisol blood sample drawn, and then they are given a synthetic version of ACTH cosentropin, and then we recheck to see the body's response in producing cortisol at 30 minutes and 60 minutes. And we want to see an appropriate rise in the level of cortisol. One thing to consider is that in a patient who has an acute apoplexy, where there may be an acute change in the pituitary function, that this ACTH stimulation test can sometimes be falsely normal. What about postoperatively? So if a patient is already determined to be adrenally insufficient after surgery, we have to give a stress dose because their own body cannot mount a stress response, and we consider surgery to be a stress to the body. And so we give a stress dose, and over the course of 48 hours, typically we bring them back to their preoperative steroid dose. And that is maintained, and typically around 4 to 6 weeks, we can, in the clinic, do a postoperative assessment to see in the off chance if their body recovered their ability to make steroids. But we know from a large series of patients in the scientific literature that the chances of doing that are pretty low, somewhere between 10 to 20%. What if preoperatively your steroid function is normal? We want to check and see, did we affect the pituitary's ability to secrete ACTH and produce steroids? So typically what we do is postoperative day 1 at 7 a.m. we draw cortisol, and if the level is okay, then we say, okay, your body's still making it, no need for any steroids. If it's low, we'll start that patient on replacement medications and retest them in 4 to 6 weeks. In some cases, if it's borderline and they're going to stay in the hospital another night, we'll just recheck it on postoperative day 2. Now, the level at which we say that it's your body is okay can vary. And there's been various reports in the literature. The earliest report in 2009 actually came out of here, where they published on a level of 15. In 2013, there was another publication where they brought that level to 10. And in 2014, there was a publication where they used a level of 4, which I think many would consider on the lower side. You know, I think the bottom line is in whatever you pick at this level, one of the concerns was, okay, let's set a higher level. We may end up putting more patients on steroids. However, we will eliminate the risk that they go home and have an adrenal crisis, okay? One of the interesting things we found, even when the group used a level of 4, yes, a few of those patients went on to have symptoms and did require going on medication, but none of the patients had a what we would consider an adrenal crisis, you know, which could be a dangerous situation. Here we use a level of 10, but I'm sure this can vary center to center. How about, let's talk about steroids specific to someone who may have Cushing's disease. So if someone has Cushing's disease, their body is already in an overproduction of steroids. And so we avoid giving them any steroids before or during surgery. And after surgery, we want to assess if there's signs that they're going into remission. And typically what we do is every 6 hours after surgery, we'll check ACTH and a cortisol level, and we'll wait over the next couple days and see, does their cortisol level bottom out? And typically we use a threshold of less than 2. And once they've bottomed out, that kind of indicates to us that they're in remission, and we can start them on steroids. And so this kind of concept can be a little bit confusing. And so if you look at this diagram from below, so the pituitary is making ACTH signal, which goes to the adrenal glands. And the adrenal glands release cortisol into the blood. Now, typically, this follows this kind of feedback circle where the brain and pituitary senses cortisol levels in the blood, and the pituitary, as a response, stops making ACTH. Okay. Now, let's say you add in a pituitary tumor, and this unwanted pituitary tumor is pumping out tons of ACTH. And as a result, the adrenal glands are making tons of cortisol. The cortisol in the blood, the tumor doesn't respond to any feedback. And that's how, in the end, we start getting high levels of cortisol in the blood. However, when this happens, the normal pituitary here does respond to that cortisol in the blood, and it completely stops making ACTH, okay? Now, what happens when we remove this pituitary tumor, the pituitary gland does not, it's essentially been atrophied and not used to making anything because of the tumor. And that's why patients kind of bottom out with their cortisol function, because the normal pituitary can't make enough. And it can take around 3 to 12 months for the pituitary to recover in order to make ACTH again. Let's talk about pain medications. So as we talked about, patients who have pituitary surgery, they can get sinus pressure, pain, headaches. In most cases, opioid medication needs may be less than 72 hours. We try and add a schedule of anti-inflammatories and Tylenol in order to decrease how much opioid medication a patient might need. And in some cases where we anticipate wide opening of spinal fluid spaces, people can sometimes get this frontal headache from drainage of spinal fluid, and that typically goes away within a day or so, but hydration and caffeine can help with that. This was a study done by our colleagues at Barrow, where they randomized patients to include intraoperative anti-inflammatories like ibuprofen and see if did that impact pain control or impact the amount of opioid medications that a patient might need. And this is a graph showing just a visual analog scale, meaning, rate your pain on a scale of 1 to 10. And this is time after surgery. And this is the standard group, and this is the group that had ibuprofen scheduled, and they had lower degrees of pain. And if we look at that same group here that got ibuprofen, their total requirement for opioid medications was less. And this was a nice study because, theoretically, one of the concerns of, Motrin or NSAIDs is that it could have some mild increase in bleeding risk. But this study showed that, at least in this population, that there was no increased risk of bleeding. All right, so now let's talk about nasal care. So in most cases, most providers will give you some nasal precautions. And what are some of the common ones? So they may tell you to avoid blowing your nose because that can increase pressure in the nose. Same thing with sneezing, to sneeze with your mouth open, because sneezing with the mouth closed can again translate that pressure into the nose. In general, to avoid heavy lifting or straining or bending over. These are kinds of things that can increase the spinal fluid pressure in the head. In many cases, your doctor may ask you to do some nasal spray or sinus irrigations. That's to keep the nasal mucosa moist and to avoid dryness and kind of avoid buildup of mucus. In many cases, a doctor may ask you to come back to the office in a week or two after surgery and do some debridements of the nasal cavity. In some cases, you may get told about the use of straws or incentive spirometry. These are also kind of common precautions. Actually, at one of our recent meetings, our colleagues at Thomas Jefferson actually did some studies where they put sensor probes in the nasal cavity of volunteers and had them, basically drink milkshakes and do incentive spirometry, and really did not find any significant change in the pressure in the nasal cavity. So these may be kind of old wives' tales in regards to straws and incentive spirometry, and probably those are okay. One thing that we do caution patients who have had, skull-base surgery through the nose is that should you ever need a feeding tube or a core pack at some point later in your life, that this should probably be placed under direct visualization by an ENT. And you may get a medical alert card to keep in your wallet or something like this. And I'll talk a little more about this a little bit later. So yeah, this is a couple of pictures of a very, very rare but possible complication and a feared complication. These are two scientific publications in our literature where a feeding tube was placed blindly and actually went through a surgical defect and into the brain cavity. And these pictures obviously are scary to look at, but a potential complication and why if one of these tubes ever needs to be placed, that it should be placed under direct visualization by an ENT physician. One of the things that I think that can help minimize the risk of this rare complication, when we do these surgeries, we like to preserve the middle turbinate. So this is a picture of what it looks like in the right nasal cavity. And we see here the S is the septum. And these turbinates are little structures that hang in the nose. And here we have the inferior turbinate. And then right above that, we have the middle turbinate. And this is the nasal floor. And in some cases, when we go to the sphenoid sinus, so we're going somewhere back in this area. And we can either move this middle turbinate to the side or we can remove it. And I think preserving this has some advantage, in the off chance someone in the future needs a feeding tube. And, when someone puts a feeding tube in, where we want it to go is low and down to the back of the nasal cavity. And once it goes in the back, it essentially it's forced down towards the stomach. But what happens if someone tries to put a tube and it's going up? Essentially the middle turbinate can deflect the tube down and send it back into the nasal cavity. So I think it can help provide some added protection against this theoretical risk. We often, after surgery, elevate the head of the bed, and that helps to facilitate nasal drainage and decrease congestion. But more importantly, it can also decrease spinal fluid pressure, and that's relevant when we do a little repair in the back of, in the sella, on the spinal fluid spaces. And this is kind of a little illustration to show that, the pressure, the spinal fluid is kind of like this. It's a column of water that's connected from the head up here to the low back. And when we're sitting upright, the pressure here near the head is much less, and the pressure kind of goes down towards the low back and away from our head where we've done a repair. Conversely, when we're flat, the spinal fluid pressure does increase in the head cavity. How about nasal quality of life? We've, in other centers, have looked at kind of what patients experience. And there's a couple quality of life scoring systems used to measure this. This is one called the SNOT score. sino-nasal outcome test, and it basically asks people to rate from 0 to 5 how you feel your symptoms are, from various things from needing to blow the nose, stuffiness, runniness, cough, going down to how it may impact things like your sleep, your productivity level, concentration, and also some of your emotional states. This was a similar survey designed by our colleagues at Barrow that asked some similar questions. And this was one of the studies they did where they looked at patients who had endoscopic pituitary surgery. And if we say, okay, this is a baseline level of someone preoperatively on average, and most patients who come in with normal sinuses because pituitary tumors, the vast majority do not affect the sinus function. When we look 2 weeks after surgery, as we expect, we've actually worsened how patients feel their sinuses are. But if we look by about 3 months, we do see in general, on average, about full recovery of nasal quality of life. Some of the factors that have been reported in the literature that can negatively impact the recovery of nasal quality of life, that's the use of splints on the septum, packing in the nose, harvesting nasoseptal flaps because that requires more nasal work, and also removal of the middle turbinates can also negatively impact nasal quality of life. The other thing that these studies found was that overall, these nasal quality of life testing did correlate with other surveys that kind of measure overall health status measures. So that tells us that it's important to preserve and protect nasal function because that has a significant impact on overall health status. This is one study that we did where, essentially one of the things you may hear is about this concept of a nasoseptal flap. And that's where we can actually, off of the septum, make a cut all the way on one side of the septum here and elevate this whole flap of tissue and mobilize it to cover the base of the skull here. Now, we found in the vast majority of straightforward pituitary cases that's really not necessary and can maybe worsen nasal morbidity. And so other centers and us use this kind of what we call a rescue flap, where we only make a small incision in one part where we need to move the mucosa down so we can access appropriately the sphenoid sinus. And should we need a nasoseptal flap at the end of the surgery, we can always come back and harvest the whole thing. And we found that in the vast majority of cases where we started with this rescue flap, we did not need to convert it to a nasoseptal flap, only in about 15% of cases. How about olfaction, the sense of smell? In some studies that have looked at this formally using formal smell tests rather than just asking patients, how is your sense of smell? About 50% of patients will have a transient decrease in sense of smell. And of course, people will often say the sense of taste feels affected as well. Even though there's no taste receptors in the nose, the sense of smell is very important for our brain's perception of taste. Now, the majority of this will recover by 1 month and some by 3 months, but permanent loss of smell is possible, but unfortunately pretty uncommon. How about sleep apnea? So sleep apnea is something that's very common in our population, in all patients. I mean, in general population in the US, prevalence is estimated to be about 20%. It's a little more common in women. In men, and it increases with age and obesity. What's relevant in our population for pituitary is patients who have acromegaly have a very high rate of sleep apnea. In one study that looked at this, it was 56% of patients who had acromegaly with a abnormal IGF level. And even in acromegaly patients who got their acromegaly under control, still 40% of them still had sleep apnea. So sleep apnea may not be something that's completely reversible with control of the IGF level. And the treatment for this is typically with positive airway pressure, these CPAP masks. What's relevant in the post-surgery population is these masks, they deliver positive pressure in the nasal cavity. And there's always this theoretical risk, could it blow air into the brain cavity? And that was kind of this theoretical concern, was why in most practices, people were hesitant to start these immediately after surgery. This was a different study, again, where we kind of, we did a survey of the North American skull base population of surgeons. And we found that most surgeons did restrict the use of CPAP, whether or not they found, they encountered spinal fluid leak during the pituitary tumor removal. And the majority of surgeons recommended to stay off CPAP for about 2 weeks after surgery. But a lot of this is not really based on any clear scientific data. And this was here actually more recently published by our colleagues at Jefferson. They used a cadaveric model where they put pressure sensors near the pituitary gland, and they measured with the use of a CPAP machine. Well, first of all, they said how much of the CPAP pressure actually reaches the sphenoid sinus. And they found that actually the majority of it does, 80 to 95%. So, if your CPAP has a pressure of 10, we can expect about, maybe a pressure of 8 getting to the sphenoid sinus. If your CPAP pressure is a setting of 20, you may get somewhere around 16 to 18 positive pressure to the sphenoid sinus. They also measured with a sensor in the pituitary area, okay, if we repaired the base of the skull using some of these different repairs, ranging from something very simple on the left to on the right, using a nasoseptal flap with absorbable glue. And really they found if we put that nasoseptal flap that there was no instances of breaches. And that in some places, and here we've done as well, in some patients who really cannot tolerate being off CPAP for a couple weeks, we've used a nasoseptal flap to allow us to bridge them onto their CPAP within a couple days. How about outcome assessment? So we've done surgery now, and your surgeon and their team wants to assess how everything is. So first of all, getting an MRI to take a look at tumor removal. There's different variations in timing of that MRI, ranging from use of intraoperative MRI suites, getting the MRI immediately within a couple days of surgery, or delaying that MRI and getting it around 6 to 12 weeks of surgery. This is our own intraoperative MRI suite. So essentially what you see here is a surgical table, and we can do surgery, and then before we leave, we kind of basically back up and bring in this big MRI magnet, take an MRI picture, send the MRI magnet back out, and assess if we need to do any further tumor removal. Some of the positives of this is immediate feedback. The negatives are the cost of the machine, increase time of the whole surgery. It typically adds around an hour or so. There was a systematic review in the literature published that did show some benefit of the use of these intraoperative MRIs in terms of how much tumor is removed. The one caveat that most of these studies, most of the papers in this systematic review were using a microscopic technique. And there's kind of a theoretical argument that the endoscopic technique may provide enhanced visualization and maybe decrease the need for these intraoperative MRIs. I think also surgical experience probably plays a role too, where with more surgical experience, rarely are you kind of surprised by the postoperative MRI. You kind of know kind of what it's going to look like, and therefore the intraoperative MRI may not have as much benefit. But there may be some value in some rare cases, in some, maybe, for example, someone who's had multiple reoperations or radiation, where the anatomy is a little bit distorted. How about the question of immediate versus delayed MRI? There's differences in practice patterns. Now, historically, MRIs were typically delayed for about 12 weeks because the use of fat grafting was much more common. And it took that time for the fat graft to kind of start dissolving so you could get a better picture. That's probably less relevant in today. Well, in the first situation, I think the use of fat is much less common, but even in cases where fat is used, there's sophisticated MRI fat suppression techniques that allow basically the radiologist to cancel out the fat, and you can get a reasonably good picture. And I think this kind of comes down to a little bit of personal preference. My own thoughts are, in cases where if I did find some tumor, I might actually take them back to surgery, immediately within the first couple of days. And maybe that's, cases of functional tumors like acromegaly or Cushing's, or something where there was very unusual anatomy or intraoperative appearance, like very fibrous tumors. Otherwise, in very straightforward cases, I think it's reasonable just to do a 6-week MRI. How about postoperative vision assessment? Patients before these surgeries typically get these Humphrey visual fields where it maps out the peripheral vision. Typically we want to repeat that after surgery. The timing of that, again, may vary by your provider, but on average, we like to get that rechecked around 2 to 3 months after there's some recovery. Patients who have bad vision and are, essentially itching to drive may get that earlier to see if their vision is improved enough that their eye doctor can clear them for driving. When we look at visual recovery, most patients do get recovery, but I always phrase this to patients in the way that, all we really do in surgery is get the pressure off the eye nerves. We really have no magic sprinkles of potion to sprinkle on the eye nerves and make them heal. And it's really up to see, once the pressure's off, how their own body and how their own eye nerves are healing. That being said, the majority of patients do get improvement. In the literature, in terms of Humphrey visual fields, about 81% of people get improvement. 40% of those are actually complete normalization. About a couple percent may have some worsening in their peripheral vision. The use of optical coherence tomography, that's where we actually take a picture of the optic nerve and measure the fiber thickness. That can actually predict visual recovery. Other things on ophthalmologic exams, like presence of atrophy, may be some poor indicators and indicate some permanent changes. And most recovery we see within the first 3 months, but certainly there's many scientific reports that show in a small percentage of patients that they can have improvement in a delayed fashion between 3 to 12 months. How about assessment of your pituitary hormones after surgery? For patients who have non-secreting tumors, of course, everyone gets a full panel before surgery. We tend to check the whole panel again at 6 weeks and again at 1 year. In patients who have Cushing's, again, we talked a little bit that we do an immediate assessment for remission. But then over the course of 3 to 12 months, once that patient's on physiologic doses of steroid or even off steroid, we can reassess for full remission by doing some of the usual tests. For acromegaly, postoperative day 1 in the morning, we check a GH level, and we like to see it less than 1, but we know that that's not really a perfect predictor. and some patients who may even be a little bit above 1 can still go into remission. Really, the gold standard test is to recheck the IGF-1 level at 12 weeks. That's the gold standard for assessing for remission in acromegaly. In prolactinomas, in some cases when we do surgery, we can check a level on postoperative day 1, and typically we do see immediate feedback of when those patients may go in remission. Last section to wrap up is complication avoidance. So we'll talk about a few things. After surgery, your providers will be very tuned to fluid and salt imbalances. And we generally have strict intakes and outputs for the nursing care for these patients, so that after surgery, your nurses may have you drink water from these so they can measure how much water you're taking in. And they may have you pee in one of these kinds of things that allow us to measure how much pee you're making. And really what we're looking for is evidence of diabetes insipidus. So let's talk about that. So the hypothalamus has neurons here that make this hormone, antidiuretic hormone, and it's passed through the pituitary stalk down to the posterior pituitary, and it's released in the blood. And that hormone works on the kidney, and it tells the kidney to reabsorb water back into the blood. So after surgery, we can sometimes see fluctuations or lack of this hormone transiently, and patients can get this diabetes insipidus. So what is that? The definition of that is hypotonic polyuria, meaning that just means dilute urine. And one of the classic definitions is making urine over 250 milliliters per hour for greater than 2 hours, and some measure of the urine, either with specific gravity or urine osmolality, to show that it's very dilute urine. We know that this number of milliliters per hour, that may be a little bit of a generous number in the sense that in other situations, patients may mobilize a lot of fluids if they got boluses of fluid in anesthesia, or in cases of acromegaly, where after they suddenly have a drop in growth hormone level that they can have diuresis. We do look at other adjuncts when we're assessing for diabetes. Of course, we want to look at the sodium level, and we also look at what's the total urine output over the course of 24 hours as well. The incidence of postoperative diabetes insipidus can vary depending on what's your definition. If we look at those kinds of generous definitions where we just look at that, 250 cc's an hour for 2 hours, the rate may be upwards of 25%. If we look at just using the definition of who actually needs medication or fluid boluses to treat it, that may be down to 5 to 10%. In the literature, there's clear risk factors of who may get DI. Certainly, craniopharyngioma patients are the highest risk, especially in some of those cases we actually have to remove the pituitary stalk. Rathke's cleft cysts also have been shown, and I think that may be related to when we do surgery, suddenly that pituitary gland is often pushed upwards, and within a few seconds we drain the cyst and that falls down, and there may be some traction on the pituitary stalk. MRI negative Cushing's disease, we tend to do very extensive explorations, and that manipulation may increase the risk in those patients as well. Fortunately, permanent diabetes insipidus after non-functional adenomas is pretty rare. The way we tell patients is essentially obey your thirst. Unfortunately, Sprite has already trademarked that, but if I could, I would trademark that for our pituitary brochures. And essentially what we do is we want to ensure that patients have good, easy access to water at their bedsides, but we don't force patients to drink. We just tell them, if you're thirsty, if you drink; if you're not thirsty, don't drink. Many patients may believe that they're peeing so much because they're drinking, when it's actually that it's chicken and egg, it's the other way around. They may have a hormone fluctuation which is causing them to pee, and we want them to keep up with that. And so we tell them, if you stop drinking, that doesn't mean you're going to stop peeing. The other thing is important to differentiate dry mouth versus thirst. Some people just from the nasal congestion, they're doing more mouth breathing, and they get dry mouth. And sometimes we'll keep, if you want an ice cube or a lozenge, that's sometimes a way you can differentiate dry mouth versus thirst. Those can help and relieve dry mouth, but if a patient is actually thirsty, that won't help, and they'll want to drink water. I think it's important to also understand, what's the circle of thirst, as I like to call it here. So what is that? So normally, the posterior pituitary is releasing this antidiuretic hormone. In cases where it's not making enough of this hormone and you go into diabetes insipidus, there's not enough signal telling the kidney to reabsorb water, and that form makes you have very dilute pee. And if there's no water reabsorption, that affects the concentration in our blood vessels, and we see that the concentration of salt goes up. However, that elevated concentration of salt, that's sensed by the brain, and the brain tells you to feel thirsty. So there's this normal circle of thirst. And so patients who develop this diabetes insipidus for pituitaries, most of them have an intact thirst mechanism, and they'll be able to regulate their sodium, and just by having access to drinking water, they can compensate for any losses in their urine. However, certainly in cases when the urine output can be extremely high, it's just too difficult to keep up with that, and we have to actively do some treatment for that. That could be where we actually give fluid in the IV, or in some cases we give these medications, either desmopressin or DDAVP, or vasopressin, which is a little bit of a shorter acting agent. And typically we'll monitor not just with intake outputs, but depending on what we think is the risk of DI, if we think it's a high risk of DI, for example, when we remove the pituitary stalk with craniopharyngiomas, we may check it every 4 hours, and we don't wait for the sodium levels to go up. We start patients immediately on some DDAVP. In medium risk patients like MR negative Cushing's, or if we did more manipulation, if it was a fibrous tumor, we may check the salt level a little less frequently, and we may just try and bridge them with a shorter acting agent, just because we think this is a transient DI. In pituitary, most pituitary adenomas that are essentially low risk, we just check sodiums as needed, and we do tend to use shorter acting agents in the short term to see if it's just transient DI. A couple of things is some pitfalls, as I mentioned, in patients with acromegaly. If they get a successful drop in their GH level, their bodies are used to retaining fluid, and they'll start having a diuresis or increased pee just from mobilization of those fluids, and that doesn't affect the salt concentration in the blood. We try and have patients without Foley catheters, even though that may be convenient in patients who are peeing more. We like to take it out to minimize risk of urine infection, but also it does serve as a little bit of a biofeedback, in the sense that if someone actually gets up to go pee and they realize they're peeing, then they may actually realize they're thirsty and then drink to compensate. This was a study that looked essentially at patients who had acromegaly, and the ones who had a successful drop in their GH level tended to diurese much more commonly, and that did not necessarily mean they were having diabetes insipidus. Last thing is about SIADH. So SIADH is the opposite of DI. It's having too much of the hormone. And that's something we can sometimes see patients develop 7 to 10 days after surgery, and that can result in pretty low levels of sodium. This is three of the largest studies in the literature with over 1,000 patients each of pituitary adenoma surgery, and overall the incidence range from around 2 to 3%. The readmissions average for when patients came back to the hospital, average in one study was around day 8 after surgery, and another study was around day 5. There's not a whole lot of great predictors of who will go on to develop this. The first study here in 2,300 patients found no real predictors of who may develop this. In another study, they found patients who had preoperative hypopituitarism were more likely to develop this. And in a third study, they found patients with Cushing's disease were more likely to develop this. What are some of the symptoms? These are the big three that I tell patients that, of course, in the first day or so, people get sinus pressure, headache. But if you're a week out from surgery, and let's say you started getting better day 4 or 5, but then suddenly day 6, 7, 8, you're feeling worse, and you're getting much worse headache, nausea, vomiting, that's a sign that you could be developing a low sodium level and should get checked out. These are some different management strategies. The most common strategy for mild low sodium is just fluid restriction. But in some cases where it's more severe, we actually give people salt either through pills or through an IV to replace that. After surgery, while people are in hospital, yeah, of course, we do check salt levels. Some places will routinely check a salt level on every patient 1 week after surgery. There's some studies showing that may not be that great in picking up patients. Sometimes we may check it at 1 week, and then at day 9 they go into it, or they went into it day 5 before we even came back for a blood draw. So there's the downside of that added visit and time. But typically, how we practice here is that we counsel, and when patients, they do come back at 1 week for an ENT visit. If a patient's having symptoms that are out of proportion to what we're expecting in terms of headache, nausea, dizziness, then we'll have them get a blood work sample to assess for this. There is some studies looking at the use of prophylactic fluid restriction, meaning that when patients are leaving the hospital after their surgery, that everyone for 2 weeks will get a fluid restriction. This is one study where they put all patients on a 1 liter a day of total fluid restriction. This is another study where they did 1.5 liter. And this is in both of these studies, they showed a significantly decreased risk in the rate of readmission for this delayed SIADH phenomenon. It's hard to imagine exactly what is this quantity, but 1 liter a day, that's essentially 4 cups of fluid in a day. CSF leak, we always consult patients to watch out for this, and sometimes it's hard to differentiate if patients from their nose may get a little bit of mucus or drops of blood. If there's some absorbable materials used, sometimes some of that may come out, or they're using nasal sprays and irrigations that go up the nose, and of course then they come out. Sometimes some of those sprays and stuff can go in the pockets of the nasal cavity, and the patient may get up, turn around, and then suddenly they get a few drops coming out. We usually tell patients that if they're concerned to stop using the spray and irrigation, and things should essentially kind of dry up over the next 6 to 8 hours. But if there's what we describe as kind of like someone left on a drippy faucet of clear fluid coming through the nose, to obviously call your surgeon and get evaluated. Last thing I'll talk about is the risk of blood clots. In general, the risk is pretty low for pituitary surgery patients, I think, because hospital times are overall pretty low, and patients, do tend to get up and walk around pretty soon after surgery. And this was a study looking at the overall rate. It's about 1 in 200 patients So still a very possible risk of a blood clot in the leg or the lung. And to prevent that, of course, we encourage that patients try and walk the same night, even if possible after surgery. We do start prophylactic blood thinning medication through belly injection shots the next day after surgery. In some patients who are high risk, we'll actually start that the same night as surgery. And when patients are in bed, not moving, or during surgery, they wear these compression stockings that help move the blood in their legs. We do know that Cushing's disease patients, this is a totally different population and definitely higher risk for getting blood clots. This was a study that found that overall in their population, 4% of patients with Cushing's got blood clots. And this was an interesting study that looked at patients with Cushing's disease, and some of those patients have Cushing's disease not from a pituitary tumor, but from an adrenal tumor. And they found really none of those patients went on to getting blood clots, but they found a reasonably high percentage of those got blood clots after transsphenoidal surgery. So maybe there's something that's some additive risk with transsphenoidal surgery that may not be seen in other surgeries. This was another study that showed that if we look at in patients with Cushing's and days after surgery, and percentage of patients who got blood clots. So each of these steps is some patient who ended up getting a blood clot. And so while we think that, around the time of surgery in the first week or two is the highest risk, there's still an added risk even 20 up to 60 days after surgery in patients with Cushing's. Some of the patients who got blood clots in the beginning were even on baby blood thinners during those events. So we do know that patients with Cushing's may be at increased risk for up to 6 months postoperatively. Our own protocol here is we treat patients with Lovenox twice daily starting the night of surgery. And even when they leave the hospital, we send them with a daily injection for 30 days postoperatively. So that wraps up the talk. I wanted to definitely thank the PNA for this opportunity and for all of their hard work and efforts to enhance knowledge for patients with pituitary diseases. And I wanted to also acknowledge a few other organizations that are, in my view, really instrumental on the back end between clinician practices and research and science. It's the Pituitary Network Society, the International Society of Pituitary Surgeons, and the North American Skull Base Society, all groups that I've worked with on research for pituitary patients. I also wanted to acknowledge some of my colleagues here who help take care of these patients, and our broader group to include neuro-ophthalmologists, neuro-oncologists, radiation, our OR nursing and clinic nurses, and we have an inpatient pituitary physician assistant, and our overall group also including our research students and fellows who help us take care of pituitary patients here. So with that, I'll wrap it up and I will turn it back over and see if there's any questions I can try and answer.
Thank you, Dr. Kshettry. And there are a few questions. The first question is, would removing the middle turbinate affect sense of smell?
Overall, I would say the risk is quite small. The majority of what we call olfactory epithelium, those are the little nerve fibers that sense smell in the nose. The majority of them are on the septum, actually at the top of the septum. Then there's a group of them that are kind of on the outer part of the nasal wall near the top. And the contribution of the middle turbinate is probably very, very minor for smell.
Okay, thank you. The next question is, at what point is surgery strongly recommended? My husband was diagnosed with a macroadenoma in September of 2018. We've been treating with medicine as he is refusing surgery. Last visit with the endocrinologist showed shrinking and hollowing out of the tumor. Can he live with a smaller tumor?
Okay, so I think one very important detail that I would need to know is this a secreting tumor? It sounds by the description that this may be a prolactinoma, and the patient is getting treated with a dopamine agonist medication. If that is the case, that is our first line treatment for the majority of prolactinomas. And if we are getting a response, both in the hormone levels and the size of the MRI, then we typically continue with the medication. In some cases where we are not getting a response, we can switch to a different medication, or we have a lot of room in most cases to increase the dose, because patients may respond differently to these medications. The main indications for prolactinoma where we do surgery is if for some reason the tumor is not responding to medication. We sometimes see that a little more in cystic prolactinomas, or if patients for some reasons cannot tolerate those medications. Those are kind of the main reasons. Now, there are some non-secreting, non-functional adenomas that when we analyze them, they do have some receptors that can respond to these dopamine agonists. But overall, that tends to be much less common, and we tend to have a very modest to no response with medications for non-functional adenomas. So based on the description by that questionnaire, or by the question, with it having a good response and hollowing out, I'm going to guess that that was probably a prolactinoma, and it looks like it's having good response so far.
She sent a message saying, yes, it was a prolactinoma, and she wanted to thank you for your response. So thank you.
Thank you.
So good guess. Next is, if a patient is on medication and is having debilitating side effects, would you advise the patient to have surgery or remain on the medication?
And I assume, is that specifically speaking for prolactinoma? Because we do, also can treat acromegaly and Cushing's sometimes with medications. I think if we're talking about prolactinoma, first of all, it depends on what the side effects are. Sometimes, we start at a certain level dose. Maybe we could drop the dose of that and see if those side effects get better, and we still have control of the pituitary tumor. Or sometimes we'll switch to another. Now, cabergoline is kind of in 2020, our first line option, as opposed to bromocriptine, which we use less frequently, but we do see some patients who may have, by chance, more side effects with cabergoline, and we can switch them to bromocriptine and give that a try. But I would say at that point, if the side effects are affecting the quality of life, I would certainly definitely explore the option of non-medication options. And really what it comes down to there is, where is the tumor? Is it nicely localized in an area that we may be able to remove completely and have some chance at a long-term essentially cure? Or, for example, is it completely encased the carotid artery and the cavernous sinus? And in that situation, we know that even with surgery, if we remove even the majority, we open up the cavernous sinus and try and remove as much as we can, we know we're not going to cure that patient, and that patient's still going to need medication. Or we have the option to do radiosurgery as a other non-surgical treatment to try and get people off of medications. So that's a long-winded answer. It kind of depends on the exact scenario, but certainly there are other non-medication options if the medications are affecting the quality of life of that patient.
Okay, thank you. Next question is there anything that can be done for someone who has Cushing's and their numbers are normal after surgery, but they feel terrible, worse than before surgery?
Yeah, this is a very, very good question, and something that we can sometimes see, not only in Cushing's, we often see this in acromegaly, where, for example, the endocrinology and surgery teams are high-fiving each other because, now we see that the patient's in remission by our biochemical numbers, and the MRI looks great, but patients still are suffering with symptoms. And so I think it's important to try and, first of all, always realize that the patient's symptoms are more than just the numbers in MRI, but also to try and dissect out what may be contributing and to see if there's things that we can impact. Now, for example, let's say that instance with Cushing's, if they're battling issues with fatigue, or, how are the other pituitary hormones? Are those still looking okay? The doses of the steroids, so as I mentioned, patients go on steroids after surgery if they're in remission. And if we just started at a normal physiologic dose, patients actually suffer quite a bit. They actually have to go on a higher dose in the beginning, and then we start trying to wean them off of them. In some cases, we may wean them off too quickly, and patients may feel worse during that weaning process, and we have to go back on. And so this is, one of those where I do rely heavily on our pituitary endocrinology experts to help tease out some of these things and give us recommendations for these patients. From my perspective, of course, I'm trying to sort out as well, is there something else that I could have affected? Are they having nasal quality of life issues that may be affecting their overall health status? And maybe there's something that I can work with my ENT colleagues to improve in that situation. Or are there other, non-pituitary medical problems that patients are suffering with? Because, Cushing's can have a lot of end organ side effects, and maybe there's already been some, damage to joints or organs, and we're still dealing with some of the issues of that, and we may need to enlist other specialists for those problems. So it's hard to give you one specific answer to that question because it's kind of general, but this is what's going on in my mind as I'm evaluating a patient who is going, in remission from our laboratory data, but still having symptoms.
Okay. Next question. What information do you give to patients who may experience adrenal insufficiency? What are the signs and symptoms to be concerned about, or what causes them to need stress dosing?
Got it. So I think there's kind of two different ways, or two different situations. One is a patient who actually has been proven to be adrenally insufficient versus a patient who is actually adrenally sufficient. So let's start with the first case scenario. Someone has already been tested, they're found to be low, and they're on medication. Okay, so we tell patients that, we normally put them on like a normal physiologic dose, kind of what someone may need on a day-to-day. However, if someone's having a stress event, our own bodies normally drive up steroids. And so for patients who are adrenally insufficient, we tell them to double up on their dose of their medication for a few days during that stress event, and to communicate that with their pituitary endocrinologist to notify them and see if there's any further adjustments in the duration. But what are these kinds of events? any sickness, cold, flu, certainly if they're having surgery, even if it's an outpatient surgery for something minor, needing anesthesia. What about patients who are shown to be adrenally sufficient, but they could be at risk for adrenal insufficiency? There's two main scenarios. One scenario is a pituitary adenoma that we're just observing, that we feel doesn't need any treatment. We always counsel patients on this theoretical risk of apoplexy, where the tumor can have a bleeding event or a swelling event, and that can cause a sudden either loss of hormone or vision problems. That's very uncommon. The general statistic from the scientific literature that I tell patients is if you have a pituitary tumor for 100 years, one time will it have one of these apoplexy events. But what are the symptoms that you could experience with this adrenal insufficiency? You could get severe headache. You could get severe nausea, vomiting, dizziness, severe like lethargy or tiredness. In very severe circumstances, that could lead to someone actually passing out, or even if it dropped the sodium level, a seizure. So these are some of the symptoms that we counsel depending on what situation they're on, whether they're adrenally sufficient or insufficient. The other one I was going to mention was not just apoplexy, but what about if someone's had radiation to their pituitary gland? We do know that if we look out 10 years later, about 50% of the people can develop pituitary hormone deficiencies. So that's another population that I will counsel on what symptoms to watch for that could be an indication of deficiency, adrenal insufficiency, for example.
Okay, thank you. Next question, what is the determining factor for medication for diabetes insipidus?
That's a very good question, and it also depends on the scenario. For example, if someone has a cranial pharyngioma where we actually remove the pituitary stalk with the tumor, we know that patient 100% is going to go into diabetes insipidus. And so we don't necessarily wait for salt levels to go up in the blood. We basically start looking at the urine output and get patients on a scheduled twice daily regimen of the medication. So that's kind of one scenario. Let's go into another scenario where we don't necessarily anticipate that if any patient, like the patient won't have any permanent diabetes insipidus. We think if they get it, it'll just be temporary. And this is where most patients with pituitary adenomas fall into. We will first see how severe the diabetes insipidus. Some patients, if we look at how much urine they make in a day, if it's untreated, some may have mild amounts and it's maybe like 5-6 liters a day. Some patients actually can really dump out a lot of urine and they're over like 10, 12, plus liters a day if left untreated. So one is the severity. Number two is how is the patient keeping up? As we mentioned, that a patient who's peeing a lot, they're going to feel thirsty and they're going to drink. If they're at a mild level and they're keeping up, there's no need to give them any medication. If they're at a severe level and they're basically having a drink, if we don't treat it, that they're going to be up all night peeing and drinking water, every hour. And yeah, of course, we want that patient to get some rest and give them a break. And if we give them medication, we like to give it, in the evening time, so that gives them a little break or rest that they can sleep at night. So I think the short answer is, it depends on how much urine output the patient is making, how well they're keeping up with it, and also what's the salt level in the blood. Those are kind of the three main determinants.
Okay. Let's see. The next question is, I've been diagnosed with Cushing's and have been working on supporting my pituitary gland naturally. And so far, 6 months in, my symptoms are almost completely gone and my numbers are getting closer to normal. Do you know of patients who have been diagnosed with Cushing's and had their tumors shrink and or disappear completely without surgery? Could you potentially work with supporting the pituitary gland with medications and or supplements enough over time to have the tumor go away?
This is a very interesting case, and offline, if that participant would email me, I'd be very interested to kind of hear his or her story on what exactly they did. The frank answer is that I don't have experience with patients with Cushing's with either homeopathic treatments or non-medical treatments. So I'm very curious on what this patient tried. Of course, I have a very biased view. The patients I see are referred by my pituitary endocrinologist for treatment. So of course, I think that gives my view quite a biased view, but I'd be very interested to hear more from this specific patient.
Okay, thank you. What would your recommendations be for a patient with a non-functioning microadenoma who is experiencing intermittent sight issues and extreme fatigue and brain fog? The last MRI was a few years ago.
Based on the fact, so I think 2 points of information is that the patient mentioned that it was non-functioning, and they mentioned micro. So the definition of micro is less than 10 millimeters. And so, this is, I think, one of the challenges is we know pituitary tumors are very common. Of course, I know we talk about this 1 in 5 campaign that's based on autopsy studies where, in routine autopsies, pituitary tumors were found in 1 in 5, and the majority of these are microadenomas. There's some studies, if we just take 1,000 volunteers, all ages, all population in the United States, and we say, if we only look at pituitary tumors that we can actually see on MRI, it's about 1.5% of the population. And when we look at least in my practice, 1.5% of people on random MRIs may have a pituitary, 1% may get another benign kind of tumor called meningioma. About 0.5% of people may have a cyst on the brain. About 0.5% of people in the population may have an aneurysm on the brain. And we're always trying to figure out, is the symptoms the patient got the MRI for because of this, or is it a coincidence? And so I think the first answer I would say is, how is the rest of the pituitary hormone functioning? For example, the thyroid function and other hormones, because deficiency in some of these areas can affect overall how people feel, and how you feel affects how your brain functions. Specifically about the comment for vision, if the tumor's not touching the eye nerves on the MRI, I personally would not have a clear explanation of the symptoms the patient's having for their vision. And that's where I would enlist my neuro-ophthalmology colleagues to help evaluate the other whole list of other causes of vision problems to make sure they don't find any specific cause outside of the pituitary.
Okay. All right. Well, that concludes the questions. So thank you so much, Dr. Kshettry, for this fascinating and valuable presentation. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and enjoy the rest of your day.